Hello, my name is Dr. Louis Mazzarelli. I'm the Director of Molecular Imaging at Lawrence Memorial and Westerly Hospitals. It's a tremendous pleasure to talk about prostate-specific membrane antigen as part of a case series, and this is our introduction. So let's talk about the epidemiology of prostate cancer. Prostate cancer is the most commonly diagnosed non-cutaneous malignancy. There are 200,000 new cases in the United States and 30,000 deaths. Currently, there are 2.7 million patients living with prostate cancer. But importantly, and why we're here, molecular imaging has become a critical tool in understanding local disease within the prostate, including extensive disease and staging, as well as evaluation of biochemically recurrent disease and metastatic disease. Let's talk about the history of molecular imaging in prostate cancer. Of course, there were bone scans, but let's talk about sodium fluoride PET. This is a bone-seeking radiotracer, and these are bone-seeking radiotracers that accumulate in bone matrix that reflect osseous blood flow and osteoblastic response. Sodium fluoride specifically demonstrates more rapid clearance and higher bone-to-background uptake compared to diphosphonates. It was FDA approved to define areas of osteoblastic activity independent of cancer type. It demonstrates a greater detection of benign processes without cancer specificity or capacity to identify local disease, nodal involvement, or visceral involvement. Let's move to cell metabolism and the history of fluciclovine. So we understand that cancer cells demonstrate marked differences in uptake compared to benign tissue, and that this differential metabolism can be applied to prostate cancer imaging. Not specific to prostate cancer, and tracer accumulation may be observed at other sites of increased cell metabolism. In other words, other cancers, infection, inflammation, benign tumors. L-leucine is an essential amino acid that activates the mammalian target of the rapamycin pathway. Deregulation of this pathway in prostate cancer leads to cancer progression and androgen independence. FABC is a radiolabeled analog of L-leucine, and it was approved in May of 2016 for the identification of sites of disease in men with biochemical recurrence. But let's get to the star of the show, which is prostate-specific membrane antigen. PSMA is a transmembrane glycoprotein. It's expressed 100 to 1,000 times higher in prostate cancer and more abundant on the surface of castrate-resistant cells. Increasing PSMA uptake correlates with higher stage of disease. It was approved initially in 2021 for PET imaging of PSMA-positive lesions in men with prostate cancer with suspected metastases who are candidates for initial therapy, and in those with suspected recurrence based on elevated serum PSA antigen and for patient selection for targeted lutetium radioligand therapy. So why has PSMA changed our prostate workflow? Well, it's now an integral part of the initial staging of biochemical recurrence pathways. Importantly, it detects disease earlier and with higher specificity than conventional imaging. It provides a one-stop whole body assessment, complementing MRI, CT. One PET-CT scan reshaped the management plan from local therapy to systemic treatment. So how has PSMA changed management? It allows for more accurate staging, defining extent of disease earlier. It guides salvage therapy, allowing for the targeting of recurrence in the prostate bed or lymph nodes. It influences RT planning, allowing for RT fields to be true disease distribution, and allows for the support of systemic therapy decisions, whether that be intensification or de-escalation. It allows for the identification of rare sites of disease, whether they be unusual places like the brain or unusual bone lesions. With respect to risk stratification, PSMA PET has now found its way within three critical guidelines. First and foremost, the NCCN, National Comprehensive Care Network Clinical Practice Guidelines, endorses PSMA PET as a replacement for CAT or bone scan in prostate cancer staging and recurrence. Similarly, the SNMI and ACR appropriate use criteria endorse the utilization of PSMA PET in the evaluation of biochemical recurrence and staging of disease. So importantly, what we've learned is that we have to start with that right patient. We have to determine if that patient is for staging and the clinical guidelines of staging and biochemical recurrence, and choose that right radiotracer, in this case PSMA PET, and deliver that right important management guidance. So let's talk about the dosimetry and biodistribution of PSMA PET. The radiation dose is comparable to other diagnostic PET radiotracers, about 3 to 5 millisieverts for typical administered activity. Let's talk about the physiologic uptake pattern. When we use PSMA, we see physiologic uptake within the kidneys, the urinary tract, the salivary glands, and the lacrimal glands. More moderate uptake is identified within the liver and spleen, and there's variable but generally lower uptake within the bowel and the bone marrow. The clinical implication is that we need to recognize the normal distribution of disease so that we can avoid false positives. Understand that photofulistat often shows lower urinary bladder activity, aiding in the pelvic bed assessment and for disease recurrence at the prostate. There are 3 agents currently approved for PSMA imaging in the United States, and these are gallium-68 PSMA-11. This is a generator or cyclotron-produced radiotracer. It has a short half-life, and it's often on-site prepped. It's widely used in initial staging and recurrence. Secondly, there's F18-DCF-PYL, which is an F18 isotope, longer half-life, centralized production and distribution, and high lesion-to-background contrast. And lastly, photofulistat, which is an F18 isotope, centralized distribution, and generally has typical lower urinary bladder activity, which can help in the assessment of the pelvic bed and the prostate. All 3 are FDA approved for prostate cancer imaging for both initial staging and BCR. All target PSMA on prostate cancer cells with similar mechanisms. Differences relate to production, gallium-68 versus F18, half-life, logistics, and biodistribution nuances. The selection of these individual radiotracers may depend on the availability, the scheduling, and the institutional workflow. So let's look at these individual PSMA imaging agents, and we'll begin with gallium-68 PSMA-11. The advantages of this radiotracer are that it's widely studied and has a long clinical track record. The on-site generator production is possible. With respect to limitations, shorter half-life, limited distribution radius, and lower injected activity, which sometimes results in a noisier image. Comparatively, F18 DCF-PYL is an F18 isotope, longer half-life, centralized distribution, and higher lesion to background contrast. The limitations are that there may be higher urinary excretion, which may obscure evaluation of the pelvic bed. Lastly, there's F18 photofulistat. It's an F18 isotope, centralized availability, and typically has lower urinary bladder activity and lower uteral activity, allowing for improved prostate bed assessment. This is the less long-term clinical experience comparatively to gallium-68. So how do we read PSMA PET? This is a qualitative, not a quantitative read process. We always begin with the MIP, the maximal intensity projection. We identify foci of uptake that are greater than physiologic uptake, and we correlate with axial PET-CT for localization. Importantly, and very importantly, always interpret within the clinical context. Understand what the patient's PSA is. Understand the pathology of the prostate, whether that be in the initial staging or in the biochemical recurrence. Understand what prior therapies the patient has undergone. Integrate the MRI and cross-sectional imaging where available, and watch for pitfalls. Physiologic uptake within the urinary tract, ganglia, benign bone lesions, ganglia within the mesentery or the sacral space, inflammatory changes. So let's look at an example of a normal PSMA PET, beginning with that MIP image, that rotating MIP. We see the normal biodistribution of uptake of PSMA. Specifically, we see that significant uptake within the lacrimal glands and also significant uptake within the kidneys. More moderate uptake is identified within the liver and the kidneys, and lesser uptake is identified within the bowel. In this case, we see more uptake within the small bowel than the large bowel, particularly within the duodenum. Where we see low activity is within the blood pool, and interesting, very little activity within the bone marrow. The other thing that we can point out in this case is the little activity we see comparatively within the GU system, specifically within the urinary bladder, no activity within the ureters, and clear visualization of 2 foci of abnormal uptake within the prostate. So in summary, prostate-specific membrane antigen, or PSMA, is highly expressed on prostate cancer cells, especially in higher grade and metastatic disease. PSMA PET provides whole-body molecular imaging with superior sensitivity to CT or bone scan. The clinical indications for PSMA are as follows: initial staging of high-risk disease, localization and biochemical recurrence, restaging, and therapy response evaluation. The advantages of PSMA PET include early detection, improved localization, and treatment planning precision. The limitations are physiologic uptake, benign mimics, and PSMA negative variants. Always understand that interpretation must occur within the clinical context. I invite you to join me for our PSMA case series, where we'll demonstrate the power of PSMA PET over a series of illustrative cases.